a pressure support option. You guys should see that when you're on your ventilators. So if you're in AC, there is no pressure support option.
That's probably where I'm confused.
Okay. So as we get through this, this is going to be one of the ways that I have said you could tell what mode you're in by what you can set. If I see pressure support option available, I have to be in SIMV something, or just plain old pressure support by itself, which is what we do to wean. If I'm in assist control, pressure support is not there. So that's the other big thing you need to understand, is that there is no PSV in AC. Can't do it. And you'll see it on your board sometimes, and you'll also see it in the settings that we're going to give you. We might tell you to put pressure support in AC, and you can't. It's not available. So you would have to tell us that that's not an option. And why is it not an option? Because there's no spontaneous breaths. My patient, if they breathe in, they're going to get a machine breath. So they could trigger it, but there's still no spontaneous breathing like there is over here. Does that make sense, you guys? Okay. So, SIMV is partial support once your rate is less than 8, or 8 or below. So when we talk about full support, partial support, once your respiratory rate is less than or equal to 8. Because if I'm in SIMV and I have a rate of 12 or 14, isn't it really like full support? Because you have a high enough rate to support the patient even if they don't breathe on their own at all. So unless your rate is low, then it's not considered partial support. AC is never partial support because we're always doing full support for the patient. So in a perfect world, this is where our patients should start off when we put them on the vent, because they need assistance, they're tired out, they're apneic, they coded, whatever. So they would start here, full support. Now, is pressure support, if I have a patient who has a pressure support breath, is that a spontaneous breath, or is it a partial support breath, do you think?
Partial support.
Why?
If they're not meeting what they need.
Because they're not eating?
No, they're not they're not meeting what they should be pulling.
Because, yeah, it's okay. It's right, because pressure support, even though it's a spontaneous, by patients doing the effort, a pressure support breath is a partial support breath because we're helping with the volume. We're helping add volume with pressure. So as long as we're doing anything to help with the tidal volume, it's considered a partial support. So pressure support ventilation is partial support. The only truly spontaneous breath is one with no pressure support or CPAP. CPAP can be considered spontaneous because all you do is have that 0 level like we saw on the pig lungs. So don't confuse these if they have pressure support. They're not really considered spontaneous from a textbook perspective because we're still assisting the patient and giving some support. So PSV is also partial support. Okay, are there any questions on this part? All right, so you have a question?
So there's no such thing as spontaneous breathing on a ventilator?
No, there is, but it would be with no pressure support.
Oh.
If you put your patient just on CPAP of 5, that's spontaneous. Because you just have that holding pressure and they're still doing all the work. You're not affecting their volume at all.
But they're ventilated, so is that just?
But that's just only at that point, not really ventilating,
Right,
if
okay.
that makes sense.
Yeah, no, it does.
That's where we do when we go to weaning.
Sure.
Okay, Jeremy?
So in assist control, if the patient is spontaneously breathing in like 100.
At 100,
Or not 100 mil.
oh, their tidal volume is 100?
Like these, will they be able to spontaneously breathe in their own like breath, like like you said, there's 100, like those little red lines, a
Uh-huh.
small amount. Were they able to do that and just control it out?
Well, could they breathe some above the 500? Is that what you're
Yeah.
saying?
Add on to the other, whatever you're giving.
Yeah, I mean, we do see some patients who pull some really big volumes. But ideally, they should only be getting what we said on there.
So you turn it down, or just does that happen common or not?
No. Most of the time we see that in SIMV, which we're slowly phasing out, which I'll get to. Nick?
Just a quick question, on assisted control, if they start to try and breathe by themselves, is there an alarm or something that goes off so we can switch them to partial support, so they can start breathing a little bit?
No, you'll see with all the negative deflections, you'll know that they're initiating every single breath.
Okay, and that's when you would switch them to try and wean them if you can see that they're constantly trying to do a breath?
Yeah, so I'll talk about this now because it always comes up. Technically, in the old world, and what seems like would make sense to you guys, we would go from AC, full support, then over here to partial support, and then work to take my patient off the vent. The problem is, SIMV is really not a good mode. It's still used in some places, but a lot of places are not using it at all. Sharon, were you guys using it at all? Yeah. We're really moving away from SIMV, and there's a couple reasons. Number one, we have found that we can go right from assist control to weaning, believe it or not. And number two, SIMV is actually not comfortable for the patient because the patient is always trying to trigger with the ventilator, or like time, the brain and the patient on the vent wants to time their breath with the ventilator breath. So they're always in their mind trying to sync with it even though they can't. And so they actually have more work of breathing and less comfort on SIMV than they do just leaving them over here. Because here, they trigger it, they get it. Yes.
So you're saying that that people are going AC to wean off the vent without going to SIMV?
Yes.
So does that mean is that why they're doing AC, like we have these right now, they're doing AC and then they're doing a bunch of SBTs throughout the day? And that's is that how they get them off, or?
Yeah, we don't normally recommend SBTs all throughout the day. Normally it's done once in the morning.
Okay.
So there'll be a number of criteria that we'll talk about later, but if your patient's on AC, low FiO2s, like everything's kind of resolved with them, and they're on low peak, we'll take them right off of AC and put them onto a weaning trial and see how they do. And that's actually the preferred method of weaning now, without even using SIMV. The old method of going AC, then to SIMV, then we would slowly go down on the rate. They're on 12, now they're on 10, now they're on 8, now they're on 6, now they're on 4, and now we'll put them on pressure support and see how they do, and then we'll extubate them. That takes like an entire day. Now, if they meet all the criteria, which we'll talk about after the Christmas break, if they meet all the criteria for weaning, we take them right off of AC and put them right on a spontaneous breathing trial and see how they do. And they wean much faster this way, which is what we want to do. We want them to come off. Yes?
Are we able to go back, like when we do our Q2 vent check, how far back can we go looking at the flats, like to see how many they're triggering? Can we go back pretty far, or is it?
Oh yeah, because it's all computerized now.
Okay,
You can
so
go
we
back.
can go.
Mhm.
Okay.
Yep. And it's really, all we want to know is, can my patient trigger a breath? I don't really pay attention to how many they trigger. I just want to know if they're doing spontaneous effort. Do they have the ability to trigger a breath? If they don't, obviously you can't wean them. But you might not even know that, and so for sure, if your patient's with it and everything, which they should be if you're trying to wean them, then you're just gonna flip them over to that spontaneous breathing trial. There are a handful of places though that still do it this way, but
Including the
it's not.
DRC?
Not a lot actually.
Oh, really?
They like you to go right to the weaning trial, the SPT as well.
Other than actually visually seeing that they're doing a spontaneous, or that they're triggering a breath, isn't there any other indications as far as on the numbers that you would tell that would lead you to believe that they're?
Oh yeah, you can tell by the rate, because if you have a set rate of 12 and the rate's 18, you know my patient has to be doing some of them, because the machine rate is set at 12. Is there any other questions? Okay, so let's add in the concept of volume control. So now we're gonna say, we got AC, so volume control. So based on what we've been talking about, we can have AC, volume control, and SIMV, volume control, right? So that's gonna be our AC-VC and our SIMV-VC, all these terms that are gonna now start to make sense. So this over here would be AC-VC, now that we know what all those crazy initials mean. And this over here would be SIMV-VC. And by my logic up here that I told you, the VC part tells the vent how to deliver the mandatory breath. So all of these mandatory breaths are gonna be volume based. And in SIMV, they're the same. The only difference between ACVC and SIMV-VC is this. My patient can take the spontaneous breaths in between the mandatory breaths, and we can have pressure support. So in a volume mode, remember volume control? Anybody know what other name it could be called from when we talked about the phases of a breath? Volume limited, yep. So this also could be called volume limited. Same thing over there. Volume control is also called volume limited. Remember, that's where I was like, you hear all these words that make no sense, and then you hear volume limited, and you're like, oh, that's volume control. I got this. So here we're gonna have, so let's say that we have our tidal volume set at 500. So every breath is gonna be set to deliver 500. And if my patient triggers, how much, what are they gonna get? 500, got it. Now, I put 500 on here, you guys, just for purposes of we're talking about it, but it's not gonna give exactly 500. It's always gonna be a little above or a little bit below. So when you go to those patient parameters to see what's actually being delivered, you never see an exact number there based on what tidal volume is set. It's just gonna give you it's gonna be close. There's always a little extra flow in the circuit, and volume, and things like that. So it's never gonna be exactly 500.
How close is close?
How close is, we set our alarm limits to be within 100 above and 100 below. So that's fine. So my volume is gonna stay constant, so what is gonna change? My pressure, yep. So pressure varies. So my pressure here might be 15, now it's 18, now it's 20, now it's 23. The exact same concept applies over here on these machine breaths. So same thing, 500, 500, 500, and a pressure that varies, 15, 18, 20. So tidal volume 500, pressure varies. So in AC, VC, oh, that's not gonna look good. That's gonna be hard to read. We can set what? Our tidal volume, our respiratory rate. I'm not gonna worry about FiO2 and PEEP because we set that on everything. So, what else? We need to set our I time, right? What else did somebody say? Flow.
Rate?
I got the rate. Tidal volume rate, I time, flow. And the other one, which some vents you can set and some you can't, is the flow pattern. All that has to do is how the flow is delivered. Is it delivered in a constant pattern, or is it delivered in what we call a decelerating, where you kind of peak up and then slowly fade down? So constant or square. This is the square, and this one is the decelerating. if you can set it, you want the decelerating. And on our bench, you can only set it on the G5 and the PB. Can't set it on the other ones.
So you can only set the decelerating on the G5 and
The PB.
the PB.
On the servo and the Draeger, you can't change it. It just defaults to whatever it defaults to.
The decelerating better just, it's more of a normal
It's
breath
more- yeah.
comfort.
And it's better for gas distribution and that, so it's just the best. In SI and VVC, I can set all the same things. What am I gonna add? Pressure support, yep. So you said all the same things. Plus ESV, so we just add pressure support on that side.
The tidal volume doesn't fluctuate on SIMV?
Not on the mandatory breath, only on the patient one.
Oh, okay, that's why if you're reading the vent, that's why it can vary on this,
Yes.
just because it's patient
Mhm.
determined.
Yep. And since we're talking about it, so normal rate, what's a good rate on the ventilator? 10 to 14 is a good starting rate. People sometimes think that my rate can be 12 to 20. Not starting on a ventilator. A good starting rate is gonna be 10 to 14. If you're going below that, it's really too low without a reason. If you're going above that, it's really too high without a reason. I can tell you that as RTs, we love 12. And don't ask me where that came from, but that's what we like. We like the rate of 12. So most people, that's where they start. And if you start people there, you'll be good. You can adjust as necessary. And what's our starting tidal volume range? 5 to 8, right? mLs per kilogram of ideal body weight. Nick.
And assisted control, what would be a reason for you to go low or high, just if the ABGs are listed?
Are you talking about on a rate? We do higher for head traumas, which we'll talk about later, and lower maybe for asthma patients, because they really, really, really have trouble on the vents. So we already have talked about normal eye time, normal flow, and then I told you normal flow pattern is decelerating. So everything's the same for SI and V. So, this up. What's an advantage, do you think?
Control mid volume.
Yep, you can control minute volume and CO2.
This is an advantage of what, AC?
ACVC or SIMV, either one. Of what these modes we're talking about right now.
Okay.
Control CO2 and minute ventilation. Remember, it's VE. Because we can control the volume, we have much better control of CO2 and minute ventilation. So like a COPDer who we're wanting to try to get him to his target CO2, which is much higher than what we're used to, this is gonna be the best way to do it. Disadvantage? What's a big disadvantage to being in volume control? Barotrauma, yep.
Pressure just flies.
So you can use ACVC anytime you want, you just gotta be aware of this. Be very, very careful. There will be one exception, which we'll talk about in a few minutes, and that's if your plateau gets high. Well, we can talk about it now. So when we're talking about barotrauma, if your plateau is greater than or equal to 30, you must switch to pressure control. Must. To ACPC, which is the next mode we're gonna talk about. Cause that's gonna be considered lung protection mode. We're now going in a mode where we're gonna control pressure and make sure that we don't cause barotrauma. So if your plateau gets to 30, switch over to ACPC, because now we need to worry about protecting our patient's lungs.